Hello and welcome to this Dentsply Academy webinar. I'd like to thank the team at Dentsply UK, that's Michael and Sasha, and Trung Nguyen from Viva Learning in California. This webinar is a collaboration with you, the audience, and thank you for those of you that posted questions. I hope I've got the answers that you were looking for. This is me, I'm John Rhodes, a specialist in endodontics in the UK. I've been working in referral endo practice for approximately 20 years. And it's not just root canal treatments that we get up to in referral practice. There's a lot of vital pulp therapies here and resorptions we deal with, as well as the usual retreatments and microsurgical endodontics. So what questions did we get? Here are a few, and we'll be covering all these topics plus some extras during the presentation. So the first topic is locating canals and the pulp floor map. I often get asked when teaching hands-on, what happens when you don't have an easy root canal? You cut an access cavity and can't actually locate the root canals at all. Well, there are a few essential ingredients for managing this, and the first one is magnification and illumination. Obviously, most endodontists will be using a microscope, but as a minimum, you really do need some form of loupe with a headlamp. The next critical thing is to make sure your access is adequate. And then we can start looking at the pulp floor map to try and work out where the canals are most likely to be. So this is the kind of view that you get of an access cavity without illumination and magnification, and this is the kind of view that I would have had as an undergraduate training back in the 1980s. As soon as you look in there with the microscope, you can see so much more detail, and here you can see the access cavity is being prepared and the roof of the pulp chamber is still intact. We're looking down those root canals. You can see little calcifications here within the root canals. And here you can see a little calcification, a little ball of dentine that's just about to drop down that palatal root. So magnification and illumination essential. In endo practice, as I've said, we use a microscope, and these are the microscopes that I use in my practice. We have video cameras, and you'll see some of the video footage from these during the presentation. The nice thing is that you get some LED illumination down the field of view, so where you're looking is highly illuminated, and this is what you're trying to get with the headlamp on your loupes. And here you can see the illumination, the LED illumination simulated from this microscope. So let's have a look at a case. This is a typical case. This molar, upper left, first molar, has had an attempt at root treatment, but only the palatal canal has been located. On the radiograph there, the buccal canals are not visible. So we're going to prepare this tooth. Now I've removed the material from the previous access cavity, and I'm now looking down into the access with my microscope, and there's two things I'm looking for. That's the previous root filling in the palatal canal. I'm now tracing out a line with a DG16 probe to see the pulp floor, which tends to be darker, and the walls, which tend to be lighter. Distally, this is much more evident. Now I've cleaned the canals with a little bit of sodium hypochlorite, and again with the DG16 I'm starting to probe at the points of the junction between the dark and light, so I can identify where the orifices of the canals are likely to be. With an LN burr, I'm going to chase out the trough between the MB1 and the MB2. I will be covering this later in the presentation, location of MB2. This just takes away some of the calcification that's at the orifice. And then with a micro opener, I can start to try and tease open the orifices of the root canals. There we are, that's the MB1, MB2, and obviously the palatal, which has got the existing root filling in there. If you want to see any of these videos again, or you want to see this case completed, then it's available on YouTube at John Rhodes Endo. So how do we then deal with these calcified canals? And this is the next stage, dealing with difficult canals. Again, we need our magnification and illumination so that we can see where we're working. And the critical thing with sclerosed canals is to make sure you've got a really good glide path, something that your rotary or reciprocating instrument can follow. This needs to be patent to at least a size 10, size 10 hand file. You need plenty of irrigant. You want any dentine chips that you're creating to come back up into your access cavity and not clog up the root canal. It's very easy to block a sclerosed canal, and then it can be difficult to regain patency. So it's important to flush the canals regularly with irrigant, recapitulate with a fine file, and always check that the canal is remaining patent. So let's have a little look at another tricky tooth. We're now going to root fill this first premolar. The dentist has had a little go at doing the root filling but couldn't locate or instrument the root canals. So the first thing we're going to see is the existing temporary filling in the access cavity. Access cavity is a little broad mesial distal. We're now looking down onto the pulp floor and using an ultrasonic tip called a Start-X tip, number 3, we're going to remove calcification from the coronal aspect where we anticipate the orifice of the root canal to be. I'm also chasing this through the isthmus between where the two canals are. Flushing with sodium hypochlorite. And now using a micro opener to see whether there's any patent root canal. I'm just seeing whether it will catch. If you use a rotary instrument, then the orifice generally shows up as a little white dot. And now this is with a size 6 file. I'm just starting to be able to get into that root canal. So I've picked up an LN burr, a small sized LN burr because the canal isn't patent. And I'm now going to remove calcified material from the coronal aspect of that orifice. You often find that the constriction is more coronal. Once you've removed that by coronal flaring, then you can progress apically very quickly. So then rinsing again with sodium hypochlorite. Picking up the micro opener or endo explorer again, just to see if that orifice is patent. And again, this time with the size 6 file, looking into the root canal there through the hole that I made with the LN burr. A little bit of lubricant, and this is the only time I really would use lubricant. And now we're in the root canal. I'm going to gently advance the file here with the apex locator lead attached until I get to the full working length. And I use a watch winding motion with gentle, small vertical increments just to make sure I don't block. And there we are, we're down to the full working length. Once the size 6 goes to the full working length, I'm now going to use the size 10 file with exactly the same action, gentle watch winding and small vertical filing action to make sure I'm patent. This is establishing my glide path down to the full working length. You can see when I get to the working length, I then just manipulate the file in the vertical direction a few times to make sure that that glide path is reproducible. There we go. And I'll be irrigating again, making sure that any dentine chips that I've created are flushed up into the access. Now I've done that and I've got a reproducible glide path, I can rapidly taper the root canal system, in this case using Wave 1 gold reciprocating instruments. In this case I am using a small instrument first to create a tapered glide path, and then I'll finish the preparation on a primary instrument. So use more irrigant, recapitulate, check for patency, and then back in with the reciprocating instrument. I let the Wave 1 Gold instrument feed into the canal and then brush into the bulkiest wall, and then it will drop down a little bit further and work a little bit more apically, and I carry on doing this. 2 or 3 passes is normally sufficient to prepare the entire working length. Check for patency with my size 10 flexor file. And now I'm in the irrigation phase of the treatment. I'm using an Endo activator to agitate the sodium hypochlorite in the root canals. Okay, we've had a couple of questions. One is, what do you use to seal rubber dam? Well, if you look at this case, here the tooth is rotated, and so the rubber dam clamp doesn't fit perfectly onto the tooth because this is buccal and palatal, and this material here is called Oroseal caulking, which is great to seal the rubber dam. If I'm doing root treatment on a bridge, then I'll pipe the caulking around the bridge and over the pontic before putting the rubber dam on, and then that will seat onto the caulking material. The Endo activator, been asked if it heats the bleach. It doesn't actually heat the bleach. All it does is agitate it. So I do use a 3% hypochlorite solution, and I've heated that in a baby bottle warmer so that it is warm. So that's the prepared root canals, nice and conservative. There they are, obturated. And then in a minute we should see the completed root canal treatment. Okay, another question that's come through. Can I give you some tips on how to use the root ZX to accurately get the working length? Okay, you need to make sure there isn't lots of hypochlorite in the pulp chamber, so you need it to be fairly dry, although they will work in a wet canal, they can't work in a soaking canal, so you need to have a little bit of moisture there, but not a lot. You want to use the largest file that's feasible, really. So although I started on a size 6, this is a tiny, tiny canal. I'd normally start with at least a size 10, but if the reading seems to be a little bit inaccurate or a little bit variable, then I'd go up a size. You need to be aware of short-circuiting on metal restorations as well. And with practice, they can become really, really accurate and really reliable. Okay, let's continue. So, next topic was removing posts. Well, this is bread and butter for an endodontist. We do loads and loads of dismantling all the time. Ultrasonics are so useful in endodontics, and the Pison ultrasonic unit is an essential. I'll also show you how to use the Rhodes post remover, which is very useful when ultrasonics aren't effective, and a very simple technique for removing a fractured post using the Masseran kit. Obviously, if you've got a screw post, then the simplest thing is to try and remove it with the wrench that was used to put it in. And a little trick with these dentatus type screws, if the head of the screw has been damaged when you're removing core material and the wrench doesn't fit anymore, then just pop a little cotton pellet over the head of the screw and then seat this on, and it will fit snugly and allow you to unscrew it. Ultrasonic tips. The StarTex kit comes with 5 tips, and these are the 2 that I use the most, number 3 and number 4. Number 3 you've already seen me using for removing calcified material over the orifices of the root canals. Number 4 with the bullet tip, this kind of ball-ended tip, is the one to use for removing posts. So here we are, this is very simple post removal. We've made a little notch in the platal aspect of the post. In comes the number 4 StarTex tip on high power. Normally I'd use water spray, but obviously for video purposes that's not possible. So we'll just play that one again. So this is a cast post in the lateral incisor. I've made a little notch in the platal aspect. I've taken my number 4 StarTex ultrasonic tip and I'm vibrating it, and you can do that for about 30-40 seconds. I would use the water spray because it can get hot without it, and that should disrupt the cement lute and allow removal of the post. Let's have a look at a slightly more tricky case. This is a cantilever bridge on a canine with a cast post in situ and a root filling, and everything looks beautiful. The root filling looks good, but there's a persistent periapical lesion. Clinically, you can see that somebody's also had a go at surgery, and this is the scarring from that surgery. This is the bridge with the canine as the abutment and the lateral incisor as the pontic. So the question in this case was, do we treat the tooth surgically or do we treat it non-surgically? Well, the patient didn't want to have more surgery, so we had no choice but to disassemble the restoration and treat this non-surgically. Treatment obviously was carried out in a single visit because the patient can't be left with no restoration anteriorly. So the first thing I've done is remove the cantilever bridge, and underneath I've got the core material. This is a cast core. You can see cement lute around that, and then the ferrule of dentine from the tooth. The first thing I'm going to do is cut a little notch in the buccal aspect of the cast core, and into that I can then insert the number 4 StarTex tip to vibrate it. Here I am working my way around the cast core, removing cement, and now I'm trying to loosen that post by applying ultrasonic vibration to it. So I'm working my way around the edges and then into that little notch that I've cut to remove the post. But in this case, after trying for a few minutes, the post didn't want to budge. So ultrasonics aren't going to be effective. And so this is an ideal opportunity to use the Rhodes post removal system. The kit consists of a series of trefines that you can use to machine the cast post, and then these extractors which screw onto the machined post. This is then a pair of forceps essentially, so that when you screw down, the beaks open and prise the post out of the root canal. So the first thing you have to do is trim down the core so that you can use one of these drills, trefine drills, to machine the post into a cylinder that you can then attach the extractor to. After that, you place an extractor. This then screws onto the post that you just prepared. Some rubber bungs to protect the tooth underneath. The forceps beaks then go between the rubber bungs and the extractor, and as you screw on the knurled screw, the beaks open, break the cement lute, and the post comes out in the extractor. And this is a very effective way of removing tricky posts. Once the tooth has then been retreated non-surgically, I put it all back together again. This is the crown and cantilever bridge re-cemented using a fibre post, and you'll see that in this slide. So this is the pre-operative radiograph here with the cast post in situ, root filling. This is my root canal retreatment, non-surgical, fibre post, and the restoration re-cemented using dual cure composite. How about this? How about when the post has fractured at gum level? One thing you shouldn't do is try and drill around the post so that you can grab it with a pair of forceps, because all that will happen is you'll remove very valuable tooth substance and end up with a very weakened tooth that then may not be restorable. The Maceran kit comes with a series of trefines. This is the trefine here that you can use to machine. Certainly if the post is circular, you can machine very conservatively around the post and remove a little bit of dentine before you apply ultrasound. So here we have a typical example. This is a post. You can see the ferrule of dentine there that the crown is seated on, but the post is sheared off below the level of the crown prep. Looking down the microscope, you can see a post there, and then this is luting cement, and we need to try and remove this very conservatively. So we use the Maceran trefine that fits just around the post, and you can see here that I've removed material from around that post in the root. Very conservative, only a minimal amount of material removed. I can now pick up my ultrasonic tip, and I could use the number 3 Startex tip if space was restricted, or if there's enough space I can use the number 4, use it on fairly high power with some water spray to vibrate the post, and I can touch that on the side of the post, I can touch it on the top of the post, just to get some ultrasonic energy into that post to try and break up the lute cement and loosen it. Now sometimes the post will come out purely with the ultrasonic vibration, but sometimes you need to use the next Maceran trefine down to grip onto the piece of fractured post and then retrieve it. And this is a very predictable way of removing fractured posts from the root canal. Okay, before we go on to management and separated instruments, I'll just have a quick look at the questions. We've got a few more coming in. Which permanent sealant do you suggest when the root canal was infected? Well, obviously we use sodium hypochlorite as the irrigant. Sealants, I tend to use AH+. Can you sharpen a trefine drill? Yes, you can. You need to get yourself a carborundum disc, and you can cut the blades back into the trefine drills. We're asking about sphektpulpotomies. It's not really something I'm going to cover in the lecture tonight. It's a vital pulp technique for teeth that have had complicated crown fractures. Essentially, you remove about 1 to 2 millimeters of pulp tissue and line that then with a bioceramic like MTA or biodentine before restoring the tooth. Okay, so answered most of those questions. Let's move on. The next topic is management of separated instruments. And really there are 3 zones to this. The green zone, which are those that are coronal and therefore can probably be attempted by just about anybody. You don't need a microscope necessarily to remove fractured instruments from this part. Amber is starting to get a bit more difficult, and really a microscope would be helpful, and certainly the techniques I'm going to show you, a microscope can be invaluable. And in the red zone, apically, well, we're into really difficult territory, and sometimes pieces of instrument that are fractured in the apical zone can only be managed surgically. So how do we go about it? There's 3 phases. First of all, you need to make some space and then either remove the instrument. If you can't remove the piece of broken instrument, then the next best thing is to bypass it. And if you really can't do that either, then obviously you leave it where it is, clean everything more coronal to it, and review the case to see whether any further action is required. You have to remember that it's not actually the file that's going to be causing any periapical abscess, although the patients tend to get quite fixated about the piece of instrument that's broken in their tooth. That's not the cause of any pain generally, it's more the bacterial infection that's triggering an immune response. So let's have a little look at something in the green zone. Here we are. This is quite an old slide. This is a profile instrument that's separated, and the entire length of the instrument has been left in the root canal. Now these are actually quite simple to remove. You can see I've cut my access cavity into the back of the tooth, and I can see the head of the profile. And now what I'm going to do is use a small ultrasonic tip to vibrate the file. When you're removing broken instruments, it's essential that the force is applied to the lateral aspect of the broken instrument. If you touch the tip of it or the head of it, then it tends to disappear further into the root canal. And certainly when you're working deep in the root canals, this is very important, because otherwise you're going to make your job harder. So you use an ultrasonic tip. You could, in this case, you could probably even use a scalar tip, but it needs to touch the side of the broken instrument. Let's have a little look at this. So I'm coming in here with my fine ultrasonic tip, and I'm going to touch that on the side of the separated file, and you'll see that after a while it loosens, and then starts to unscrew, coming right up into the access, and now I can retrieve that very simply. So here we are, that's the access cavity. That's before I applied the ultrasound, and this is after applying ultrasound. It's literally unscrewed itself from within the root canal. And there's the piece of fractured instrument removed from the root. So an instrument fractured in the green zone, quite simple to remove and successful. There we are, that's the case obturated, and then 3 months down the line you can see there's been some good evidence of bony healing. Okay, well, what happens when we get down into the amber and red zone? Well, things are more complicated here, and really you need to be able to see where you're working, so a microscope at this stage is more or less essential. There are several stages. The first thing you need to do is produce what's called an unimpeded exit. In other words, if you're trying to remove this piece of fractured instrument, it went in on the red line, it needs to come out on the white line. So straight line access is absolutely essential. You need to make a little bit of space in order to use your ultrasonics and for the file to come out, the piece of broken file to come out. Ultrasonic vibration again, and this time it's with really tiny tips, and then retrieval. Now often it's very easy to get the piece of fractured instrument to vibrate and wobble within the root canal, but retrieval can be difficult, and I'll show you a technique for doing that in a minute. In order to create the space, we modify Gates-Glidden burr, and this is then called a belly burr. I wouldn't go any bigger than a size 3 because the Gates-Gliddens are starting to get quite large then, so I'd only use a size 2 or a size 3 Gates-Glidden burr and literally just machine off the bullet tip so that it becomes a cutting instrument that will create a flat platform over the head of the broken instrument. The instrument removal system is an excellent way of retrieving the loosened pieces of fractured instrument. You'll see this in action in a minute. This comes with core drills, which can be used similar to the Maceran trephine to cut gently around the piece of fractured instrument, and then a remover, which consists of a tube with a little window in it and a rod down the middle which grips the piece of fractured instrument so you can retrieve it. So let's have a little look at the case. This is a molar here, lower right molar, and you can see there's a little bit of broken instrument in one of the medial canals. That's the gutta-perca root filling in the root canals. You can see I've made myself generous access through the amalgam restoration because I need space in order to retrieve the instrument. And now I've used the modified Gates-Glidden burr number 2 to cut down to the head of the instrument, and this is the head of that instrument here, looking down there with the microscope. And now I can use a modified Endo sonar file to gently apply ultrasound around the edges of that broken instrument, and here we are, this is it removed. Normally put cotton wool in the other orifices because it's very embarrassing if you retrieve it from one only for it to disappear down another prepared root canal, so I normally pack those with a little bit of cotton wool just whilst I'm retrieving the broken instrument. And there we are, back onto the root treatment. We've got our working length estimation radiograph there. This is the pre-op, again with the broken instrument in the mesial canal, and that's been retrieved and the case has been completed. And you can see that you can just see where the Gates-Glidden burr has done its work there. There's a tiny little step, but it's a conservative approach, and it hasn't damaged the root canal or risked perforating it. So let's have a little look at the IRS in action. Here we are. This is a premolar tooth with a couple of pieces of broken instrument in it, and we're going to retrieve those using the IRS system. I'm using a Startex number 3 tip first to remove cement from the coronal aspect of the root canal. There we are, so continuing to remove cement from around the pieces of broken instrument. Looking down inside with the microscope. And start to visualize the head of the broken instrument. Now this is endomethasone paste, set endomethasone paste that's in the root canal there. I'm going to irrigate with some sodium hypochlorite. Okay, on high power, we can just see the head of, in this case, a headstrom file in the root canal. And here is the IRS system. This is the tube. I tend to hold it in a pair of forceps because it's easier then to visualize where you're working. If you've got big fat fingers in the way, you can't see it going over the head of the instrument. Now then I insert the rod, excuse my fingers, and the screw thread runs anti-clockwise. If it doesn't seat straight away, give it a little turn clockwise, and then once it's engaged, it will turn anti-clockwise until you feel it lock the piece of broken instrument into the tube. I then use the tweezers to gently retrieve, and there's the piece of broken instrument in the remover. This tooth also had a piece of silver point in there, and you can see that through the microscope there. So I'm just inserting the tube back over that, and again rotate the same as before, anti-clockwise to lock it. And then gently retrieve. So the IRS system is very useful for removing pieces of fractured instrument from the mid-third, the amber zone of the root canal. Here we have another fairly typical case. This is a canine with a piece of, actually two pieces of broken headstrom. There's one big long piece and then a little piece more apically. So the coronal piece, the piece that's more coronally placed, a very long piece, can be removed very simply with the IRS system. This is an IRS extractor. And then we've got to manage this piece that's more apical, and you can see it's actually slipped further apically. So I'm using a braiding technique here. I'm getting a file alongside it, and then I'll use that to grip it and move it into the coronal part of the root canal, and then retrieve it. But working apically is very difficult. Obviously, sometimes you can't even see this deep down into the root canal with the microscope. Okay, we're on to some more questions now. Nice quick one. I always struggle to find the MB2 canal and upper molars. What is the best tip? Well, this is a good question. This is a prepared roots, obviously root canals of an upper molar. And the technique is this. The first canal I'd aim for is the palatal canal. You can see the pulp floor map here. This is darker and the walls are lighter, just like we saw right at the beginning. So we found the palatal canal. Now we find another canal. In this case, it's the MB1. I then locate the distal buccal canal. So it's like a triangulation. I'm looking for these points. You can see that the pulp floor map extends into points, and at the end of the point, that's normally where you find the orifice of the root canal. So I found those three. I now imagine a line between the MB1 and the palatal canal. I'm looking here, and you can just see a little isthmus, this little white line traveling from the MB1. So if I can see that, then the next thing I do is use either an ultrasonic tip or an LN burr, small LN burr, to machine from the MB1 along this line towards the palatal. And I'm looking at a point that's more or less perpendicular to the distal buccal canal. And this is the most likely space, or most likely position, that I'm going to find the MB2. So you need to imagine a line from MB1 to palatal. Follow any, if you can see an isthmus, follow it with a burr, with an LN burr, or with your ultrasonic tip. And when you get to about this point, this is the most likely zone where you're going to find the MB2. Okay, next question. should we retreat a root canal treated tooth with no radiological issue, 2D, or clinical symptoms, but being left just with temporary filling, and when? Okay, now I've kind of broken this question up a little bit. The first interesting thing is the fact that it hasn't got a radiological issue in 2D, doesn't have any clinical symptoms, and it's just got a temporary filling. So let's have a little look at this in a bit more detail. Two-dimensional radiographs can be quite difficult to interpret, and certainly in endodontic practice we use CBCT quite a lot to help with diagnosis and treatment of root-treated teeth. Now this X-ray, or radiograph rather, shows two teeth with potential radiolucencies, but they're not particularly clear. And this is quite common because until most of the cortical plate has been eroded, you often don't see the lesion on a radiograph. Now the CBCT of these same teeth shows quite clear periapical radiolucencies. You can see there's actually been quite a lot of destruction around the root tips, but the cortical plate is essentially still intact. So CBCT is quite useful. It gives you that third dimension. And so you can't always be sure that your 2D radiograph is showing you everything that you need to. Now I thought we'd break this down a bit further and think about the worst case scenario, and maybe the tooth hasn't got a temporary in it. What happens if you've got a tooth that's been left open to the oral environment or has got caries in it? What do you do then? Well, there's quite a little bit of controversy in the literature because the papers that look at the management of these cases in vitro, in other words, trying to simulate the clinical situation, suggest that the root canal of the tooth can get contaminated really quickly by bacteria. And this paper by Torabinejad, we've got total contamination of the root canal in about 19 days. So this is a laterally condensed root canal that's been exposed to bacteria. And again, unsealed obturated root canals are all getting recontaminated in about 30 days in vitro. However, when you look at the same situation in vivo, and this is a very nice paper by Riccucci and some lovely histology slides in this paper, he looked at teeth that had been exposed in the oral cavity in vivo, some of them for up to 3 years, I believe, and then looked to see how far bacteria penetrated. And in 55 cases, they all had to have a good root canal treatment, and this is quite critical, but they were either exposed to caries or the oral cavity. And few of them had periapical lesions on a radiograph. Obviously, that can possibly be a problem because you may have seen something on a CBCT, but overall coronal leakage didn't seem to be a significant problem. In other words, they didn't see bacteria penetrating all the way down the root-filled tooth when there was a good root filling. And again, the follow-up to that study in vivo showed a similar picture. So optimally prepared and filled root canals can resist the penetration of bacteria, even when they're exposed directly to the oral cavity. So he did see bacteria coronally, and obviously that can be managed very simply. You can just remove some of the GP and irrigate the tooth. But there weren't great colonies of bacteria apically, and this kind of was in contrast to what had been shown in vitro. Of course, there are other papers which look at the quality of coronal restoration and root filling, and really these are in agreement with that Riccucci paper because it shows that if you have a good endo in the tooth, then it does provide an excellent barrier to coronal leakage and bacterial ingress. And so the answer to that question, should we retreat the tooth with no radiological issue in 2 dimensions, if it hasn't got any clinical symptoms and if it has a good root filling, and that is essential then in this case the dentist can carry straight on with restoration. There's no reason to retreat that root canal. Okay, so the next question is, how do I weigh up whether to start doing an endo myself or refer out? Well, this is quite a difficult question, in fact, because the availability of skilled specialists and materials will vary greatly depending on which country you're working in. And of course, everybody works in a different surgery setting, and everybody kind of develops their own comfort zone, and you soon learn your limitations. So really, it's not a very easy question to answer, and it's a very personal thing and something that we all as individuals have to decide what we are going to try and what we're not. And then you go on a course and maybe develop your skills and then start with the simple cases and work up from there. However, there are a few things that are definitely more challenging than others, and these are perhaps those. Very highly curved canals, and you can sometimes spot this on a radiograph, or as we've seen earlier on in the presentation, very sclerosed canals. These are going to be much more difficult to manage, and certainly the use of fine files, recapitulation, plenty of irrigation really helps in the management of those cases. Trauma cases can be difficult to manage. Not only are often the patients younger and maybe not quite so compliant, but you're dealing with immature roots and potential to carry out regenerative type endodontics. These are very new techniques, and it's very critical that the surgical field is managed well and no bacteria get into the root canal system during treatment. So some of the trauma cases probably would be something that you might want to refer out. As we've seen, instrument removal in the mid and apical third, that's really difficult. Amber and red zone, you do really need a microscope to use those techniques, and the IRS kit, which is an excellent way of retrieving bits of broken instrument from the root canals. It's a lot easier to use it if you can actually see down the root canal with the microscope and place it over the piece of fractured instrument. Perhaps patients with really complex medical histories. We do see quite a lot of those people on bisphosphonates and things where it's critical a tooth is saved and not extracted. Maybe something that you'd want to consider referring out. And microsurgical endodontics, well, all surgical endodontic treatment now is carried out using a microscope, so if you don't really have one, then this is perhaps something that you would want to consider referring. So let's have a look at one of these more challenging cases. How about this one? This is a molar here with an irreversible pulpitis. And just looking at the plain x-ray, you can see that the root appears to do a 90-degree bend. What kind of things could happen when you're trying to treat one of these? Well, you could certainly, the canal is very fine, you could block the canal, you could certainly ledge at the point where there's a sudden curvature, or you could even separate an instrument as well in a really tight curved canal like this. So a case like this, to manage a curve like that, you need to make sure that you've definitely got a reproducible patent glide path before you use any rotary instrument. But modern instruments like Wave 1 Gold will easily negotiate a curve such as this, as long as they've got a path to follow. You need to use lots of irrigant to make sure that dentine chips that are being created within the root canal system are flushed out of the root canal and into your access cavity. It's much easier to remove dentine chips from the coronal area than it is from down in the root canal. So this case is quite interesting. You look at the plane view using the rin holder and you can see that yes, there's two mesobuccal canals as we'd anticipate, and they do go around almost a 90-degree bend. But it's quite fun sometimes with these cases to just have a look at the view that you don't always see. And this is a distal angulated view, and you can see that the MB2 canal actually flips around and does more than 90 degrees. So it's a challenging case. You just need to take it nice and slowly, keep going in and recapitulating. I think in this particular case, I probably replaced the flexor files 2 or 3 times to make sure that I didn't leave any file behind and that the canal was always kept patent. Trauma cases, well, this is quite a complicated case. A 20-year-old lady with discoloured front tooth. Obviously, you want to treat this conservatively. You don't putting crowns on the teeth like that. It's a nice tooth. It's just a very darkened colour. She had trauma a long time previously, and somebody had an attempt at root filling the tooth. But a very wide immature canal is not easy to obturate using lateral condensation. The cones you never really get good adaptation of the cones to the wall of the tooth. And so in this case, the tooth is still contaminated with bacteria, and there's a periapical lesion at the apex. So this is the kind of case that we'd obturate using MTA or biodentine, something like that, where you've got a very wide open apex. And this is much easier if you can visualize it with the microscope, because using a microscope you can see right down to the apex. You can place a membrane or barrier if you need to, and then pack your material onto that. So here you can see the case has been, all the GP has been removed. The root canal has been irrigated with sodium hypochlorite. We've used ultrasonics to agitate that irrigant to make sure the root canal is as clean as possible. And then we've obturated with a bioceramic material here, MTA or biodentine. There's a little pellet of GP on top of that, and then conventional restorative material composite in the access. And at 3 months, you can see some evidence of healing. This would be reviewed again at about 6 months and then a year. And you'd expect that after cleaning the root canal and disinfecting it to heal. But it's not an easy case to manage using ordinary type techniques, ordinary lateral condensation type techniques. It's not very easy to obturate a root canal that's very wide and maybe has an immature root. And then the tooth was bleached using an internal bleaching technique, and then the composite restored or replaced and restored on the incisal tip. And this is the final result. You see the colour match is very nice after internal whitening. And then finally, we might want to consider referring cases that require surgery. All endodontic surgery is really carried out using a microscope these days because the success rates are being shown to be considerably higher. We don't use semilunar incisions anymore. It's a papillar sparing incision or submarginal flap. The root end is resected without a bevel, like the good old days when you had a big bevel on there. With ultrasonic preparation, again, we can now prepare down the root canal from the apex 5 to 7 millimeters and fill that, clean that space, and then fill it with IRM or MTA. So this is a typical kind of surgical case. I've got a post crown on there. These crowns actually look really nice, and the patient didn't want this dismantled in order to carry out non-surgical root canal retreatment, but there is a large lesion on there, and so this is amenable to a surgical approach. With the ultrasonic tips, we should be able to clean all the way from the apex right down to the tip of the post. So the first thing I'm doing is just, I've raised a flap. You can see it's a papillar sparing incision. I've curetted the lesion, I've got the root tip, and I've removed the apical 3 millimeters of the tip of the root with a high-speed surgical burr. I'm now going to use an ultrasonic tip to start removing the gutta perca from the root canal. This can be quite tricky, and you need to make sure that the ultrasonic instrument is touching the walls of the canal and removing any little bits. So there I leapt in with the micro mirror, surgical micro mirror, just to check to see if there are any fragments. There were a few fragments of GP still remaining in the root canal, so I've gone back in with my 7 millimeter long ultrasonic tip. And again, checking with the micro mirror, and I'm looking down there and I can see right down the prepared root canal. High power. And you can see the tip of the post there at the bottom of the root end preparation. The preparation is then dried with a sterile paper point in this case. Sealed with IRM. That's packed into place. And a further increment. Burnishing it across the resected root tip. And that's the completed root end filling. You can see the IRM goes all the way down to the post. It's a nice conservative preparation. We haven't removed loads of dentine, but we've managed to clean right down to the tip of the post. And that's modern microsurgical endodontics. Okay, now we've got plenty of time for a few questions.